This lecture describes the basic mechanical features of the cardiac pump, the factors that influence and/or regulate cardiac output, and the sources of energy and the energy costs required for myocardial activity. The mechanical function of the heart can be described by the pressure, volume, and flow changes that occur within it during one cardiac cycle. A cardiac cycle is defined as one complete sequence of contraction and relaxation. The normal mechanical events of cycle of the left heart pump are correlated into a figure. This important figure summarized a great deal of information and should be studied carefully. The diastolic phase of the cardiac cycle begins with the opening of the atrioventricular valves. Unless otherwise noted, systole and diastole denote phases of ventricular operation. As shown in figure, this mitral valve opens when left ventricle pressure decreases below left atrial pressure and the period of ventricular fillings begin. Blood that had previously accumulated in the atrium behind the closed mitral valve empties rapidly into the ventricle, and this causes initial decrease in atrial pressure. Later, the pressures in both chambers slowly increase together as the atrium and ventricle continue passively filling with blood returning to the heart through the veins. Atrial contraction is initiated near the end of ventricular diastole by the depolarization of the atrial muscle cells, which cause the P wave of the electrocardiogram. As the atrial muscle cells develop tension and shorten, atrial pressure rises and additional amount of blood is forced into the ventricles. At normal heart rates, atrial contraction is not essential for adequate ventricular fillings. This is evident in the figure showing that the ventricles has nearly reached its maximum and diastolic volume before atrial contraction begins. Atrial contraction plays increasingly significant role in ventricular fillings as heart rate increases because the time interval between beats for passive fillings becomes progressively shorter. Note that throughout diastole, atrial and ventricular pressures are almost the same. This is because the normal open mitral valve has very little resistance to floor and thus only a very small atrial ventricular pressure difference is necessary to produce ventricular filling. Ventricular systole begins when the action potential breaks through the atrioventricular node and sweeps over the ventricular muscle, resulting in the QRS complex of the electrocardiogram. Contraction of the ventricular muscle cells causes intraventricular pressure to increase above that in the atrium, which causes abrupt closure of atrioventricular valve. Pressure in the left ventricle continues to increase sharply as the ventricular contraction intensifies. When the left ventricular pressure exceeds that in the aorta, the aortic valve opens. The period of time between mitral valve closure and aortic valve opening is referred to as isovolumetric contraction phase because during this interval, the ventricle is a closed chamber with a fixed volume. Ventricular ejection begins with the opening of the aortic valve. In the early ejection, blood enters the aorta rapidly and causes the pressure there to rise. Pressure builds simultaneously in both the ventricle and the aorta as the ventricular muscle cells continue to contract in early systole. This interval is often called the rapid ejection period. Left ventricular and aortic pressure ultimately reach a maximum called peak systolic pressure. At this point, the strength of ventricular muscle contraction begins to wane. Muscle shortening and ejection continue, but at a reduced rate. Aortic pressure begins to decrease because blood is leaving the aorta and large arteries faster than blood is entering from the left ventricle. Throughout ejection, there are very small pressure differences between the left ventricle and the aorta because the aortic valve orifice is so large that it presents very little resistance to flow. Eventually, the strength of the ventricular contraction diminishes to the point where interventricular pressure decreases below aortic pressure. This causes abrupt closure of aortic valve, a dip called the incisura or necrotic notch appears in aortic pressure trace because a small volume of aortic blood must flow backward to fill the aortic valve leaflets as they close. After aortic valve closure, interventricular pressure decreases rapidly as the ventricular muscle relaxes. For a brief interval called the isovolumetric relaxation phase, the mitral valve is also closed. Ultimately, intraventricular pressure decreased below atrial pressure. The atrioventricular valve opens and a new cardiac cycle begins. Note that atrial pressure progressively increases during ventricular systole because blood continues to return to the heart and fill the atrium. The increased atrial pressure at the end of systole promotes rapid ventricular fillings once the atrioventricular valve opens to begin the next heart cycle. The ventricle has reached its minimum end systolic volume at the time of aortic valve closure. The amount of blood ejection for the ventricle during a single beat, the stroke volume, is equal to ventricular end diastolic volume minus ventricular end systolic volume. During the early, most rapid phase of systolic ejection, the aorta distends because more blood begins put into it from the left heart than is leaving it to the systemic organs. That distension is caused by increasing pressure within the aorta. During the later, weakening phase of cardiac ejection is opposite is true. The overall result is that the aortic pressure reached a maximum value, systolic pressure, near the middle of ventricular systole. During diastole, the arterial pressure is maintained by the elastic recoil of walls of the aorta and other large arteries. Nonetheless, aortic pressure gradually decreases during diastole as the aorta supplies blood to the systemic vascular beds. The lowest aortic pressure reached at the end of diastole is called diastolic pressure. Differences between diastolic and peak systolic pressure in the aorta is called the arterial pulse pressure. Typical values for systolic and diastolic pressure in the aorta are 120 and 80 mm per mercury, respectively, with a pulse pressure of 40 mm per mercury. At a normal resting heart rate of about 70 beats per minute, the heart spans approximately 2/3 of the cardiac cycle in diastole and 1/3 in systole. When increases in heart rate occur, both diastolic and systolic intervals become shorter. Action potential duration are shortened and conduction velocity is increased. Contraction and relaxation rates are also enhanced. This shortening of the systolic interval tends to blunt the potential adverse effects of increasing heart rate on diastolic filling time. Because the entire heart is served by a single electrical excitation system, similar mechanical events occur almost simultaneously in both the left heart and the right heart. Both ventricles have synchronous systolic and diastolic periods and have the valves of the right and left heart normally open and closer nearly in unison. Because the two sides of the heart are arranged in the series in their circulation, they must pump the same amount of blood and therefore must have the same cardiac output. The major difference between the right and left pumps is in the magnitude of the peak systolic pressure. The pressures developed by the right heart are considerably lower than those for the left heart. This is because the pulmonary vessels provide considerably less resistance to blood flow than that offered collectively by those of systemic organs. Therefore, less arterial pressure is required to drive the cardiac output through the lungs than through the systemic organs. Typical pulmonary artery systolic and diastolic pressure are 25 and 8 mm per mercury, respectively. The pressure pulsations that occur in the right atrium are transmitted in retrograde fashion to the large veins near the heart. This pulsation can be visualized in the neck over the jugular veins in recumbent individuals. They are collectively referred to as jugular venous pulse and can provide clinically useful information about the heart. Atrial contraction produces the first pressure peak called the A wave. The C wave, which follows shortly thereafter, coincides with onset of the ventricular systole and is caused by initial building of the tricuspid valve into the right atrium. Right atrial pressure decreases after the C wave because of atrial relaxation and the A downward displacements of the tricuspid valve during ventricular emptying. Right atrial pressure then begins to increase toward a third peak, the V wave, at the central veins and right atrium filled behind a closed tricuspid valve with blood returning to the heart from the peripheral organs. With the opening of the tricuspid valve at the conclusion of ventricular systole, right atrial pressure again decreases as blood moves into the relaxed right ventricle. Shortly afterward, right atrial pressure begins to increase once more toward the next A wave as returning blood fills the central veins, the right atrium and right ventricle together during diastole. A record of the heart sounds which occur in the cardiac cycle associated with heartbeat. These sounds are normally heard by auscultation with the stethoscope placed on the chest and are described as lap-dub sound. These sounds are due to vibration in the heart tissues that are produced as the blood flow is suddenly speeded or slowed with the contraction and relaxation of the heart chambers, and with the opening and closing of the valves. The first part of the heart sound, S1 or lap, occurs at the beginning of systole because of the abrupt closure of ultraventricular valves. This produced vibrations of the cardiac structures and the blood in the ventricular chambers. S1 can be heard most clearly by placing the stethoscope over the apex of the heart. Note that this sound occurs immediately after the QRS complex of the electrocardiogram. The second heart sound, dub or S2, arises from the closure of the aortic and pulmonic valves at the beginning of the period of isovolumetric or ventricular relaxation. This sound is heard at about the time of the T wave in the electrocardiogram. The pulmonic valve usually closes slightly after the aortic valve. Because this discrepancy is enhanced during the inspiratory phase of the respiratory cycle. Inspiration causes what is referred to as the physiological splitting of the second heart sound. The discrepancy in valve closure during inspiration may range from 30 to 60 milliseconds. One of the factors that leads to prolonged ejections of the right ventricle during inspiration decrease intrathoracic pressure that accompanies inspiration transiently, enhance venous return and diastolic filling of the right heart. The third and fourth heart sounds are normally present. When they are present, however, they along with S1, S2 produce what are called gallop rhythm, resembling the sounds of the galloping horse. When present, the third heart sound occurs shortly after S2 during the period of rapid passive ventricular filling and in combination with heart sounds S1 and S2 produces what is called ventricular gallop rhythm. Also, S3 may sometimes be detected in normal children. It is heard more commonly in patients with left ventricular failure. The first heart sound, which occasionally is heard shortly before S1, is associated with atrial contraction and rapid active filling of the ventricle. Thus, the combination of S1, S2, and S4 sounds produces what is called an atrial gallop rhythm. The presence of S4 often indicates increased ventricular diastolic stiffness, which can occur with several cardiac disease states. atrioventricular pressure and volume are intimately linked to the tension and length of the cardiac muscle cells in the ventricular wall. On the figure shows the correspondence between the ventricular pressure, volume loop, and a cardiac muscle length tension loop during one cardiac cycle. It is clear that cardiac muscle length tension behavior is the underlying basis for ventricular function. Each major phase of the ventricular cardiac cycle has a corresponding phase of cardiac muscle length and tension change. In diastolic ventricular filling, for example, the progressive increase in ventricular pressure stretches the resting cardiac muscle to greater length along its resting length tension curve and causes a corresponding increase in muscle tension. And diastolic ventricular pressure is referred to as ventricular preload because it sets the end diastolic ventricular volume and therefore the resting length of the cardiac muscle fibers at the end of diastole. At the onset of systole, the ventricular muscle cells develop potential isometrically during the isovolumetric contraction phase, and intraventricular pressure increases accordingly. After the intraventricular pressure increases sufficiently to open the outlet valve, ventricular ejection begins as a consequence of ventricular muscle shortening. Systemic arterial pressure is often referred to as ventricular afterload because it determines the tension that must be developed by cardiac muscle fibers before they can shorten. It should be noted that other factors that influence the actual wall tension required to eject blood from the ventricle, such as end diastolic volume, velocity of contraction, viscosity of the blood, do contribute to ventricular afterload. During cardiac ejection, cardiac muscle is simultaneously generating active tension and shortening. The stroke volume is determined by how far ventricular muscle cells are able to shorten during contraction. This, as already discussed, depends on the length-tension relationship of the cardiac muscle cells and the load against which they are shortening. Once shortening ceases and the output valve closes, the cardiac muscle cells relax isometrically. Ventricular wall tension and intraventricular pressure decrease in unison during isovolumetric relaxation. Throughout the heart are clumps and stands of specialized cardiac muscle tissue whose fibers contain only a few myofibrils. Instead of contraction, this part initiate and distribute impulses, cardiac impulses, throughout the myocardium. They comprise the cardiac conduction system, which coordinates the events of the cardiac cycle. A key portion of this conduction system is called the sinoatrial node, SA node. It consists of a small elongate mass of specialized cardiac muscle tissue just beneath the epicardium. It's located in the posterior wall of the right atrium, below the opening of the superior vena cava, and its fibers are continuous with those of the atrial syncytium. The membranes of the nodal cells are in contact with one another, and the cells have ability to excite themselves. That is, without being stimulated by nerve fibers or any other outside agents. The nodal cells initiate impulses that spread into the surrounding myocardium and stimulate the cardiac muscle fibers to contract. Furthermore, this activity is rhythmic. The sinoatrial node initiates one impulse after another, 70 to 80 times a minute. Thus, it's responsible for the rhythmic contractions of the heart and is often called the pacemaker. As the cardiac impulse travels from the sinoatrial node into the atrial syncytium, the right and left atria contract almost simultaneously. Instead of passing directly into the ventricular syncytium, which is separated from the atrial syncytium by the fibrous skeleton of the heart, the cardiac impulse passes along fibers of the conduction system that are continuous with atrial muscle fibers. These conducting fibers lead to a mass of specialized cardiac muscle tissue called the atrioventricular node or AV node. This node is located in the floor of the right atrium near the septum that separates the atria, interatrial septum, and just beneath the endocardium. It provides the only normal conduction pathway between the atria and ventricular syncytia. The fibers that conduct the cardiac impulse into the atrioventricular node, junctional fibers, have very small diameters, and because small fibers conduct impulses slowly, they cause the impulse to be delayed. The impulse is delayed still more as it travels through the atrioventricular node, and this delay allows time for the atrial to empty and the ventricles to fill with blood. Once the cardiac impulse reaches the distal side of the atrioventricular node, it passes into a group of the large fibers that make up the AV bundle, atrioventricular bundle or bundle of His, and the impulse moves rapidly through them. The atrioventricular bundle enters the upper part of the interventricular septum and divides into right and left branches that lie just beneath the endocardium. About halfway down the septum, the branches gives rise to enlarged Purkinje fibers. The Purkinje fibers spread from interventricular septum into the papillary muscles, which project inward from the ventricular walls and then continue downward to the apex of the heart. There they curve around the tips of the ventricles and pass upward over the lateral walls of these chambers. Along the way, the Purkinje fibers give off many small branches, which become continuous with cardiac muscle fibers. The muscle fibers in the ventricular walls are arranged in irregular whorls, so that when they are stimulated by the impulses on the Purkinje fibers, the ventricular walls contract with a twisting motion. This action squeezes or wrings the blood out of the ventricular chambers and forces it into the arteries. The primary function of the heart is to pump the blood to the body cells, and when the needs of these cells change, the quantity of the blood pumped must change also. For example, during a strenuous exercise, the amount of blood required by the skeletal muscle increases greatly, and the rate of the heartbeat increases in response to this need. Since the sinoatrial node normally controls the heart rate, changes in this rate often involves factors that affect the pacemaker. These include the motor impulses carried on the parasympathetic and sympathetic nerve fibers. The parasympathetic fibers that supply the heart arise from nervus in the medulla oblongata and make up parts of the vagal nerves. Most of these fibers branch to the sinoatrial and atrioventricular nodes. When the nerve impulses reach their endings, these fibers secrete acetylcholine, which causes a decrease in sinoatrial and atrioventricular nodal activity. As a result, the rate of heartbeat decreases. The vagus nerves seems to carry impulses continually to the sinoatrial and atrioventricular nodes. These impulses impose a braking action on the heart. Consequently, parasympathetic activity can cause the heart rate to change in either direction. An increase in the impulses causes slowing of the heart, and decrease in the impulses releases the parasympathetic brake and allows the heartbeat to increase. Sympathetic fibers reach the heart by means of the accelerator nerve, whose branches join the sinoatrial and atrioventricular nodes, as well as other areas of the atrial and ventricular myocardium. The ending of these fibers secrete norepinephrine in response to nerve impulses, and this substance causes an increase in the rate and the force of myocardial contractions. A normal balance between the inhibitory effects of the parasympathetic fibers and the excitatory effects of the sympathetic fibers is maintained by the cardiac control center of the medulla oblongata. In this region of the brain, masses of neurons functions as cardioinhibitor and cardioaccelerator reflex centers. These centers receive sensory impulses from various parts of the circulatory system and relay motor impulses to the heart in response. For example, receptors that are sensitively to strain are located in certain regions of the aorta, aortic sinus and aortic arch, and in the carotid arteries. These receptors, called piezoreceptors or baroreceptors, can detect changes in the blood pressure. Thus, if the pressure rises, the receptors are stretched, and they signal the cardioinhibitor center in the medulla oblongata. In response, the medulla sends parasympathetic motor impulses to the heart, causing the heart rate and force of contraction to decrease. This action also caused blood pressure to drop toward the normal level. Another regulatory reflex involves pressure receptors in the vena cava near the entrances to the right atrium. If the blood pressure increases abnormally in these vessels, the receptors signal the cardioaccelerator center, and sympathetic impulses flow to the heart. As a result, the heart rate and force of contraction increase, and the venous blood pressure is reduced. The cardiac control center can also be influenced by impulses from the cerebrum or hypothalamus. Such impulses may cause the heart rate to decrease, as occurs when a person faints following an emotional upset, or they may cause the heart rate to increase during period of anxiety. Two other factors that influence the heart rate are temperature change and the presence of various ions. Heart action is increased by rising body temperature, which accounts for the fact that heart rate usually increases during fever. On the other hand, cardiac activity is decreased by abnormally low body temperature. Consequently, a patient's body temperature is sometimes deliberately lowered, hypothermia, to slow the heart during surgery. Of the ions that influence heart action, the most important are potassium and calcium ions. Also, homeostatic mechanisms normally maintain the concentration of these substances with narrow range. This mechanism sometimes fail, and the consequences can be serious or even fatal. recording of the electrical changes that occur in the myocardium during a cardiac cycle is called an electrocardiogram, ECG. These changes result from depolarization and repolarization associated with the action potentials occurring in contraction cardiac muscle fibers. Because the body fluids can conduct electrical currents, such changes can be detected on the surface of the body. To record an ECG, metal electrodes are placed at certain location on the skin. These electrodes are connected by wires to an instrument that responds to very weak electrical changes by causing a pen or stylus to mark on a moving strip of paper. When the instrument is operating, up and down movements of the pen corresponds to electrical changes occurring within the body as a result of myocardial activity. Because the paper moves past the pen at no rate, the distance between pen deflections can be used to measure the time elapsing between various phases of the cardiac cycle. The normal ECG pattern includes several deflections or waves during each cardiac cycle. Between cycles, the muscle fibers remain polarized and no detectable electrical changes occur. Consequently, the pen doesn't move and simply marks along the baseline as the paper passes through the instrument. However, when the sinoatrial node triggers and cardiac impulse, the atrial fibers are stimulated to depolarize. Electrical changes occurs. As a result, the pen is deflected, and when this electrical changes is completed, the pen returns to the base position. This first pen movement produces a P wave that is caused by depolarization of the atrial fibers just before they contract. When the cardiac impulse reaches the ventricular fibers, they are stimulated to depolarize rapidly. Because the ventricular walls are much more extensive than those of the atria, the amount of electrical change is greater, and the pen is deflected to a greater degree than before. As before, when the electrical changes is completed, the pen returns to the baseline, leaving a mark called the QRS complex, which usually consists of a Q wave, an R wave, and S wave. This complex appears just prior to contraction of the ventricular walls. Near the end of the ECG pattern, the pen is deflected once again, producing a T wave. This wave is caused by the electrical changes occurring as the ventricular muscle fibers become repolarized relatively slowly. This record of the atrial repolarization is missing from pattern because the atrial fibers repolarize at the same time that the ventricular fibers depolarize. Thus, the recording of the atrial repolarization is obscured by the QRS complex. ECG patterns are especially important because they allow the physician to assess the heart ability to conduct impulses and therefore to judge its condition. For example, the time period between the beginning of P wave and the beginning of a QRS complex, PQ interval or PR interval, if the initial wave is upright, indicates how long it takes for cardiac impulse to travel from the sinoatrial node through the atrioventricular node. If ischemia or other problems involving the fibers of the atrioventricular conduction pathway are present, this PQ interval sometimes increases. Similarly, if the atrioventricular bundle is injured, the duration of the QRS complex may increase, because it may take longer for impulse to spread throughout the ventricular walls. So slight variations in heart action sometimes occur normally. Marked changes in the usual rate or rhythm may suggest cardiovascular disease. Such abnormal actions, termed cardiac arrhythmias, include following. First, tachycardia. Tachycardia is characterized by an abnormally fast heartbeat, usually over 100 beats per minute. This condition may be caused by such factors as an increase in body temperature, nodal stimulation by sympathetic fibers, the presence of various drugs or hormones, heart disease, excitement, exercise, anemia, or shock. Second, bradycardia. Bradycardia means a slow heart rate, usually one that is less than 60 beats per minute. It may be caused by decreased body temperature, nodal stimulation by parasympathetic impulses, or the presence of certain drugs. It also may occur during sleep. Athletes sometimes have unusual slow heartbeats because their hearts have developed the ability to pump a greater than normal volume of blood with each beat. Third, premature heartbeats. A premature beat is one that occurs before it is expected in a normal series of cardiac cycles. Such an occurrence is probably caused by cardiac impulses originated from unusual ectopic regions of the heart. That is, the impulse originates from a site other than the sinoatrial node. Cardiac impulses may arise from ischemic tissue or from muscle fibers that are irritated by the effects of disease or drugs. Fourth, flutter. A heart chamber is said to flutter when it is contraction regularly, but at very rapid rate, such as 250 to 350 contractions per minute. Also, normal hearts may flutter occasionally. This condition is more likely to be due to damage to the myocardium. Fifth, fibrillation. Fibrillation is also characterized by rapid heart action, but unlike flutter, the accompanying contractions are uncoordinated because small regions of the myocardium contract and relax independently of all the other areas. As a result, the myocardium fails to contract as a whole, and the walls of the fibrillating chambers are completely ineffective in pumping blood. Also, a person may survive atrial fibrillation because blood can continue to move through the heart. If the ventricles are functional, ventricular fibrillation is very likely to cause death. In fact, ventricular fibrillation is the most common cause of sudden cardiac death. That is the unexpected collapse and death of a seemingly healthy person. The ventricles can be stimulated to fibrillate by a variety of factors, including ischemia associated with obstruction of a coronary artery or coronary occlusion, electric shock, traumatic injury to the heart or chest wall, or toxic effects of various drugs. Once the ventricles are fibrillating, normal cardiac rhythm is not likely to be restored unless the heart can be defibrillated. Under such conditions, if circulation is not re-established within a few minutes, the person may suffer irreparable damage to the cerebral cortex, and may die. Defibrillation is accomplished by exposing fibrillating myocardium to a strong electric current for a short time. This action causes all of the muscle fiber within the myocardium to become depolarized simultaneously, so that all contractile activity ceases momentarily. It's hoped that within the next instant, the sinoatrial node will begin to function and the normal rhythm will be reestablished. Such a restoring of the normal cardiac rhythm is called cardioversion. 6. Arrhythmias due to conduction disorders. Any interference or block in cardiac impulse conduction may cause arrhythmia. The type of arrhythmia produced, however, varies with the location and extent of the block. Related to this is the fact that certain cardiac tissue other than sinoatrial node can function as pacemakers. The sinoatrial node usually initiates 70 to 80 heartbeats per minute. If the sinoatrial node is damaged, impulses originating in the atrioventricular node may travel upward into the atrial myocardium and downward into the ventricular walls, stimulating them to contract. Under the influence of the atrioventricular node action as a secondary pacemaker, the heart may continue to pump blood, but at a rate of 40 to 60 beats per minute. Similarly, the Purkinje fibers can initiate cardiac impulses, causing the heart to contract 15 to 40 times per minute. A patient who has such a disorders of the cardiac conduction system might be treated with artificial pacemaker. This device includes electrical pulse generator, a lead wire that communicates with a portion of myocardium. The pulse generator contains a permanent battery that serves as an energy source and a microprocessor that can sense the cardiac rhythm. The microprocessor can also signal the heart to increase or decrease its rate of contraction as it's needed. An artificial pacemaker can be surgically implanted beneath the patient's skin, and its functions can be adjusted from the outside by means of the external programmer.